Our next speaker is Dr. Glen Baker. Dr. Baker is a professor of psychiatry and neuroscience at the University of Alberta. He is also director of the Neurochemical Research Unit. He is a former chair of the Department of Psychiatry at the same university, the past president of the Canadian College of Neuropsychopharmacology, and former TR1 Canada Research Chair. Dr. Baker is currently a fellow of the Canadian Academy of the Health Sciences. He was a series co-editor for the book series called Neurometics, and he has also published more than 300 peer-reviewed scientific articles. And his main research interests are mechanism of action and metabolism of psychiatric drugs, etiology of psychiatric and neurological disorders, and drug development, with a specific focus on neuroprotection. And now he is going to present reactive aldehydes. What are their roles in neuropsychiatric disorders? The stage is yours.
Thank you, Mr. Chair. I'd like to also thank the local organizing committee for inviting me back again to this great conference in such a beautiful part of the world, and our Turkish colleagues, as usual, are wonderful hosts. Today I'm going to talk about reactive aldehydes, and which many of you may not be too familiar with, but there's been increased literature on these compounds and their possible interaction with neuropsychiatric disorders. So here's a number of these reactive aldehydes that are present in several reports of their presence in higher amounts than usually expected in a number of neurological and psychiatric disorders. Methyl-glyoxal at the top, Alzheimer's disease particularly, acrolein, which is very common reactive aldehyde. It's also an environmental problem. 3-aminopropionol, which is formed from polyamines in the brain. 4-hydroxynonenal at the bottom here has been reported in a number of neuropsychiatric disorders. Malonaldehyde from the lipids, and formaldehyde again on top of this. We'll talk about Alzheimer's disease. So where do these reactive aldehydes come from, and what sort of problems do they create? Due to the catalytic activity of the amino oxidase called primary amino oxidase, and it acts on a number of amines in the CNS to produce methyl-glyoxal and formaldehyde, which are potentially toxic aldehydes. Oxidative stress and lipid peroxidation can lead to excessive formation of 4-hydroxynonenal, or HME, in the aldehyde, and polyamine metabolism and also lipid peroxidation, oxidative stress, can lead to increased formation of acrolein and 3-aminopropionol. These can then form adducts with amino acids, proteins, nucleic acids, and aminophospholipid. And because of that, we get inhibition of DNA, RNA, and protein synthesis. You get disruption of protein and cell membrane function, and interference with various mitochondrial pathways, all of which are tied up with various neuropsychiatric disorders. Just to give you some examples here of three disorders: Alzheimer's disease, Parkinson's disease, and multiple sclerosis, or MS. In Alzheimer's disease, we have increased acrolein and hydroxynonenal adducts in the reported in the hippocampus, adducts of hydroxynonenal, acrolein, and NDA co-localized with neurofibrillary tangles, which are characteristic of Alzheimer's disease. Get increased levels of methyl-glyoxal in the CSF of Alzheimer's patients, and increased hydroxynonenal adducts and extractable acrolein in the hippocampus of patients with preclinical Alzheimer's disease pathology. So these are all potential biomarkers. In Parkinson's disease, you get increased MDA, HNE, and acrolein content in the substantia nigra. Acrolein and MDA modified alpha-synuclein is found in the substantia nigra of Parkinson patients, and increased MDA and HNE in the CSF of Parkinson's patients. As well, there's MDA and HNE adducts, so these form adducts with proteins, for example, in frontal cortex and substantia nigra of preclinical Parkinson's patients that exhibit neuropathological changes without the onsets of symptoms. There's been a lot of work done with reactive aldehydes in multiple sclerosis in recent years, and it's shown an increase in MDA content in the CSF of MS patients, an increased MDA content in oligodendrocyte-like cells, and active lesions in the patients. And as I'll mention later, there's a lot of work suggesting that acrolein may be involved in the etiology of multiple sclerosis as well. Just a cartoon here showing that formaldehyde, methyl dioxide, malondialdehyde, and 4-hydroxynonenal promote formation of A-beta, the oligomers and protofibrils, as well as increase the size of the aggregates in beta amyloid. So there's involvement in beta amyloid formation and formation of neurofibrillary tangles in Alzheimer's. This is a recent paper from Miami Gonzalez group in toxicology and members. And this talks about chronic effects of acrolein intake for 8 weeks in rats. As I mentioned, acrolein can be an environmental problem. It's a byproduct, for example, of the petroleum industry. So if we look at the first slide, underneath test, you can see the vehicle results here, and acrolein. So the Morris-Watermays test, which is an indicator of spatial learning and memory, there's longer escape latencies to find the hidden platform in the acrolein animals. There's a loss of neurons in the hippocampus, the CA1 region. And there's also, this goes back to what Faisal was talking about, intense astroglia activation in the hippocampus. GFAP here is a marker of astroglial neural inflammation. So marked increases in a number of potentially neurodegenerative aspects after chronic administration of acrolein to rats. Again, this is just a brief one. I'm going to talk about it for very long, but acrolein can affect both beta secretases and alpha secretase activity in the hippocampus and the cortex. And the result effect here is that you get increased formation of A-beta or beta amyloid and its abnormal folding by the upregulation of the beta secretase and downregulation of ADAM10, which is the gene for alpha secretase activity. I'm just going to spend a few slides now talking about potential drugs that we can use to counteract the effects of some of these reactive aldehydes. And phenazine is a very old drug. It's an NAO inhibitor. It's been around since the 1950s. Still used as an antidepressant. It's also actually a very good drug for treating things like panic disorder, social anxiety disorder. But because it is an NAO inhibitor, there's the possible food-drug interactions. It's not used as extensively as it should be, but there's been a marked increase of interest in NAO inhibitors in recent years because of the potential neuroprotective because of that, it's readily oxidized to its active metabolite, or phenylethylamine hydrazine, or PDH. And another interesting thing about phenolzine and PDH is that they're both quite strong inhibitors of GABA transaminases. So when you give phenolzine, you actually get marked increases in brain levels of not only the monogenic amines by inhibiting monoamine oxidase, but increased levels of GABA as well. And that's due to the effects of phenolzine itself and this active metabolite. So as I said, there's been increased interest in phenolzine in recent years because of its potential neuroprotective effects. And this shows the effects of phenolzine in a gerbil model of global ischemia, that we get almost exactly the same effects if we administer the active metabolite PDH. So this is protection of hippocampal CA1 neurons in the ischemic gerbil model caused by occlusion of the carotid arteries for 5 minutes and reperfusion. We then wait 3 hours before administering phenolzine. And this is that window of 3 to 6 hours, for example, you have a stroke patient. So this is why we chose the 3 hour time window. You can see in the animals, the sham animals that have the occlusion of the carotid arteries, that your percent loss of neurons is about 80%. This is in the ischemia animals. And when you give phenolzine, that drops to about 35 to 40%. So there's a neuroprotective effect here. The ischemia itself causes about 80% of neuron cell loss in this area, and about 50 to 60% greater by giving phenolzine, which we administer for 7 days. We've also done some studies in multiple sclerosis in recent years, looked at the EAE model of mouse model of multiple sclerosis, which is probably the most common model that's used for MS as an animal model. And phenolzine definitely improves functional outcomes in the EAE model of multiple sclerosis. So up here you have the clinical scores, similar to what would probably be called an antidepressant effect with phenolzine. So the animals' appearance is much better, they seem to react much better to their environment. Gross locomotor function here in the EAE animals is greatly reduced. You give phenolzine, you get a marked improvement in the gross locomotor function, and the same with exploratory activity. You get an increase in exploratory activity with the phenolzine as well. So it does seem to be having a marked improvement effect in multiple sclerosis, and we're now pursuing that further. So what's responsible for the neuroprotective mechanisms of both phenolzine and its metabolite PDH? There's a number of things. First of all, I mentioned they both elevate brain levels of GABA markedly, so that's going to counteract any cytotoxic effects of glutamate. They both are strong inhibitors of an enzyme called primary amine oxidase, and this is responsible for the conversion of some amines in the brain to formaldehyde and methylglyoxal. So they're going to cause a reduction in the brain levels of these reactive aldehydes. And they have another effect on reactive aldehydes, and that's the fact that they can actually interact with them chemically directly and cause sequestration of reactive aldehydes. I'll just spend a couple slides here talking about that. So primary amine oxidase converts methylene and amino acetone, so these are endogenous amines, to the respective toxic aldehydes formaldehyde and methylglyoxal. Activity and expression of primary amine oxidase is reported to be increased in Alzheimer's disease, diabetes, heart failure, atherosclerosis, and hemorrhagic and ischemic stroke. Vascular primary amine oxidase is co-localized with cerebrovascular amyloid beta amyloid deposits in postmortem Alzheimer's show you with these with phenolphthalein and its primary metabolite. Both of them are very potent inhibitors of this enzyme, primary remoxidase, which is responsible for the formation of these toxic aldehydes. So we get formation of amino acetone gets converted by primary amino oxidase to methyl glyoxal. The thiamine gets converted to formaldehyde. These are these reactive aldehydes are very difficult to assay in brain tissue. We're now working on this. We're looking at both the protein atoms of the toxic aldehydes as well as the free toxic aldehydes. In the first case, we're using microblat methods, modern methods. In the second case, we're using gas chromatography combined with mass spectrometry. We're now just about at the point where we can measure both the atoms and the free toxic aldehydes in brain tissue. So, as phenolphthalein and pH are both reported to inhibit primary oxidase in vitro, we hypothesized that these drugs will increase brain levels of thiamine. So until we got these assays for the actual aldehydes themselves, we were using an indirect method where we measured the thiamine, which is the substrate that's being used by primary oxidase to produce formaldehyde. So if you are inhibiting primary oxidase and causing a reduction in formaldehyde formation in the brain, you should get an increase in whole brain thiamine levels as an indirect indicator of reduced formaldehyde formation. And this is why we found these examples of 6 hours and 12 hours after giving animals phenolphthalein or pH. You see that pH metabolite is particularly effective against this, but both of them cause an increase in brain thiamine levels, indicating that they are probably decreasing brain levels of formaldehyde. So neuroprotective mechanisms of phenolphthalein and pH, as I said, inhibition of primary amino oxidase and sequestration of reactive aldehydes. And here's an example of how both phenolphthalein and pH, because they've got this active hydrazine group on them, can react with aldehydes to form a hydrazone product, which is much less reactive than the parent reactive aldehyde does. So both of these are active in that regard. So this is some GCNS studies where we looked at the ability of both phenolphthalein and pH to sequester the aldehydes, and pretty well all the ones I talked about initially: acrolein, methyl glyoxal, formaldehyde, 4-hydroxyquinone, and the aldehyde are sequestered by these compounds. This is an example of sequestration of acrolein, which is one that we're particularly concerned with in Alberta because of the oil industry. You can see that percent of acrolein remaining in solution here. We incubated it with both phenolphthalein and pH over 30 minutes, and you can see a marked reduction in the levels of acrolein. So these are relatively cheap drugs. Old drugs have been around for a long time. It may be useful in treating a number of neurodegenerative disorders because of their ability to sequester these reactive aldehydes. We've also just finished looking at some cultured mouse cortical neurons and the effects of acrolein on them. So you can see cell viability when you give acrolein here is much reduced, and you get a nice dose response curve with both phenolphthalein and with pH. Although pH isn't quite as effective as a weaker effect, but quite a marked reversal of the acrolein toxicity by This is some work we did with Paul Wood a few years ago, looking at 3-amino propanol effects. It's another reactive aldehyde that's produced during the metabolism of polyamines, and it's a very toxic compound. We're looking at aldehydes here as an indicator of neurotoxicity. And you can see that acronym causes a marked increase of LDH release compared to the control situation, but you can bring it back just about completely to the control situation by incubating with phenolzine. Again, here's just a dose response curve. We have a dose response bar graph with giving various concentrations of phenolzine. So we can reduce this. And this is in this 3-hour window that would be very important for something like stroke, where you want to get as good recovery as you possibly can. This is another study that was done just recently by CCNP in 2013, where they're looking at phenolzine as a possible neuroprotective agent in a rat model of traumatic brain injury. And they've shown here, this is the effects of 4-hydroxynonenal, and you can see the phenolzine markedly reduce that effect. So in isolated brain mitochondria, in this study, phenolzine attenuated 4-hydroxynonenal induced oxidative damage. The rats were given a single administration of phenolzine 15 minutes after the traumatic brain injury, and it preserved mitochondrial function and improved cortical tissue repair. This is another study that's been done in MS. Except quite a bit of interest in the possibility of possible role of acrolein in the etiology of MS. And in this study, we show the anti-acrolein treatment improves outcome and alleviates myelin damage, and then again, this EAE model of multiple sclerosis. And here, the treatment that we used was hydralazine, which has got that same hydrazine grouping on the phenolzine has, and it reduced demyelination of spinal cord produced by acrolein and improved the clinical score of the animals quite markedly. So there's a lot of number of groups now are looking at more closely the possible involvement of acrolein in multiple sclerosis. So in conclusion, reactive aldehydes seem to